Hey, good morning, everyone. Let me know if you can hear me okay. All right, perfect. Thank you, Abby. We'll get started here in about a minute or two. We have a couple questions to go over up front here, and then we'll get into the lecture. It looks like our exam is going to be next week, so this will be the last week of material for the exam. That'll be good. All right, well, it's 8 o'clock, so let's go ahead and begin here. Of course, if you have questions, post them up in the chat or on the sticky board. Either one are fine. I have a couple to go over here first. Someone says, from my experiences working the floor in a hospital, I've encountered an enema that is referred to as the golden enema. Sounds pretty expensive. When looking at its composition, it's partially made of soap. Is there a specific reason for this? Yeah, that's usually not something handled by a pharmacy a lot of times. Usually it's like on the nursing side of things where they handle a lot of that, because soap is not really like, a pharmacy thing. It's not really a product that we normally stock or regulate. But yeah, there's like something called soap suds enema. Again, I think a lot of it has to do with similar properties to some of the hyperosmotic ones we've talked about previously. So it can cause sort of like a hyperosmolar draw of water into the colon, can be kind of irritating to that tissue, all of which can lead to increased peristalsis. So there are other things that have been used. You can use tap water, you can use soap suds, different things can be used. But we don't usually recommend them. They can tend to lead to electrolyte disturbances if used in patients who have issues like renal dysfunction, elderly and really young ones. So that's why I don't usually recommend that a lot of times, but it can still be used, depending on the provider. Someone said this may not matter long term, but will substance P antagonists ultimately affect the patient's digestion during chemo in the following 2 days, since substance P helps with peristalsis and the GI tract? Not to my knowledge. I've not ever heard that it's caused any issues in terms of GI effects, other than just preventing the nausea and vomiting, which, if anything, helps them to eat. But I'm not aware of any issues with that in particular. So. Some said in the case of juvenile RA taking Actemra on birth control, would it be better to switch the patient from an oral contraceptive to maybe an IUD as a form of birth control, or inform her to add another method of birth control to her regimen to prevent pregnancy? Yeah, both of those things are good ideas. We'll talk about that later when we get into the OB-GYN section later in this course. But yeah, so either having something that's like a locally acting source for like hormones, such as like an IUD, whether it be copper or something like, levonorgestrel or something like that. Or you can have them use backup methods of birth control. You could do like a depot shot. There are different options there. It's really the estrogen where the liver effects of Actemra can be a problem. So that would be my answer to that. But we'll get more into it later on. Someone says, without getting too far into it, curious why hydroxychloroquine is thought to be used for COVID. This has to do with the fact that so hydroxychloroquine is kind of kind of a cousin to a drug called chloroquine, which is actually an anti-malarial drug. And so it's, it has a history of being somewhat anti-infective. And so I think some people had a thought that perhaps the hydroxychloroquine helped with like preventing the virus from getting into the cell, and things like that. I think we found now that does not provide any benefit in terms of like hospitalizations or serious illness. There's also side effects you can run into in terms of like eye toxicity and things like that. So that is not currently recommended. But yeah, thank you for the questions. I appreciate that. And anything else, you can post them up there. Even weirdo, not weirdo, but even like off topic things. Like I don't mind talking about those. Those are fun. Keep things interesting for me for sure. Okay, so you guys hopefully have the slides available to you. I think I made everything available. All right, and so we'll go ahead and get started here. So let's talk about pain management. Now there's not like a lot of specific like ortho drugs, so to speak, but a lot of pain comes about from orthopedic concerns, and so if this is a good segue to talk about pain management in general. So we're going to get into that and talk about the medications that we use primarily for analgesia in our patients. So talking about pain management. This is a huge reason why people come and see you, either in the urgent cares or in the ERs and primary cares. And I mean, everyone can experience pain. And so this is a big thing that patients are going to come see you for. So you want to be able to know how to manage it appropriately, because not all pain is the same, and not all people can be treated exactly the same, because pain is a inherently subjective sort of thing, unfortunately. And so a lot of people will experience it. A lot of people will come seeking therapy for it. A lot of money lost because people can't go to work and have disabilities and things like that. So this is a big thing to know about. And a lot of times you're going to find barriers to patients getting good pain relief, because it could be issues of the patient not wanting to partake of therapy because they're worrying about it being addictive. They're worried about side effects. A lot of times healthcare providers can be a big source for barriers. I'm kind of out of frame here a little bit. Healthcare providers can be a big source of barriers for your patients getting pain relief too. I'm sure some of you might have experience working in ERs and things like that, where someone coming in complaining of pain, and the provider just says, "Oh, they're just here seeking drugs. They just want drugs." It's very easy to get cynical, and I encourage you guys to at least keep an open mind when dealing with patients complaining of pain, because there's a lot of people who express it differently, and just because they don't express it the way that you think they should does not mean they don't have legitimate concerns, right? Or legitimate issues there. But there's also a lot of formal training and things like that. Healthcare providers, you don't want your patients to get addicted to anything, and so that can be somewhat irrational fear, but it can be, a concern. And again, from a system related issue, there's not a lot of money in pain management unless you're doing some sort of actual procedure. There's not great reimbursement for it. And just, relatively few pain practitioners, people are specifically trained in this. So there's a lot of challenges to this for sure. And, pain is, again, as I mentioned, it's kind of subjective. So if you could find a way to objectively measure someone's pain, you'd probably be a trillionaire, because you would fix a lot of issues. But unfortunately, a lot of times we have to say it is whatever the patient says it is. So if they're saying, if they're sitting quietly and calmly and their vital signs look good, but they're telling you they're having the most excruciating pain of their entire lives, and you kind of have to take them at their word, because there's not really another way to really measure that. Certainly the pain assessment is really important. This is something that you guys are going to get a lot of experience with in terms of getting history from the patient, in terms of doing your physical exam and things like that. Some things can be obvious, like if someone has appendicitis and you touch their belly, they're going to be crying out in pain, right? Sometimes it can be more subtle, especially with chronic pain, especially with issues where patients maybe have had to deal with this for the past decade or more, and they've gotten so used to it that maybe they don't have a lot of outward signs of pain that they're going to be expressing, as opposed to someone who maybe got into a car accident and now their femur sticking out of their leg, right? So different ways it can present. Certainly, though, when you're assessing your patients, it's good to get an idea in terms of their medication history, so what they're taking currently. Some things may be exacerbating their pain, some things may be helping it. Certainly your physical assessment is super important in terms of determining where the pain's at, how they describe it, because different types of pain may be managed differently. You definitely want to check out their organ function in terms of like kidneys and liver. make sure they can process the meds appropriately. Otherwise, they may have buildup of levels of their drugs and may lead to some toxicities there. And things like their psychosocial history. So learning about histories of substance abuse may lead you to choose one med class versus another. So for instance, some patients, they know they have a history of substance abuse, and so they say, well, I don't want to receive any of that, and you should take that into account. Or, you know, if they have a family history, there's certainly genetic components to addiction for sure, and other substance use issues. And then also take into account things like anxiety, depression. They can certainly exacerbate pain, and which can then exacerbate their anxiety and depression. So a lot of it can be sort of cyclical, and so if you can try to manage that as well, that would be good, because you can get two birds with one stone in a lot of ways. When dealing with patients, pain is important to consider. It's not just one steady level of pain all the time. Especially with chronic pain, you're going to find that it has peaks and valleys, right? And it's important to consider how we're going to manage that. And so you may find patients will be managed both with control for their pain on a basal level, meaning they're going to have meds that are on board all the time just to deal with their baseline level of pain. And then as they have spikes of pain, breakthrough pain, they may have, you know, intermittent medications for that as well. So it's not uncommon to see patients who are on extended and immediate acting pain medications, because you have to deal with kind of both of those, right? You don't want to be treating them so heavily on the basal side that you know, kind of cause a lot of excess side effects. You don't want to overdo it to try to cover all that breakthrough pain, but it's okay to have, you know, something that covers them throughout most of the day, and then maybe when they're more active, getting up, moving around, doing things to exacerbate their pain, then you have something that can cover those breakthrough points, right? So typically when you want to think about how to manage patients, you kind of think about a ladder approach. You want to think about kind of working up the ladder of, in terms of like strength of the medications that we're going to use, sort of with opioids being at the top. Obviously intravenous opioids probably being the strongest things that we have. But you know, if someone comes in and they're complaining of a strain or sprain or something like that, you know, you don't have to bust out the opioids right away. You can start off with more mild things and then kind of work your ways up. Now, if a patient comes in and their femur is obviously visible from their, you know, sticking out their leg after a car accident or something, then perhaps you should go ahead and go with the opioids. You know, so you don't have to start at the bottom of the ladder. You can go right to the top if it seems clinically appropriate to you based on your judgment. So, again, you can always give more. Oftentimes it's hard to take back what you've given. So that is a consideration as well, to make sure you can say, okay, well, if I need to step it up, here's what my next plan is. You know, you always want to save something in your pocket, so that way you have a backup plan if need be. A lot of times injuries and pain are going to be coming about, or the pain experienced from injuries is going to be coming about from inflammation. And so this is either due to like tissue insult, could be chemically related, foreign protein infection, anything like that. And it all has pretty much the same general flow. And you know, we've covered rheumatology, and so we've seen a lot of inflammation-based sort of pain before in terms of that. And so this is all the same. So, you know, I'm not going to belabor this too much, but if we can do things to try to limit this inflammation, that's going to be a big help, right? Just like we talked about NSAIDs and use for rheumatoid arthritis, we're going to kind of touch on that again, go over a few different NSAIDs we might not have covered already. But if we can help to decrease the production of a lot of these inflammatory cytokines and histamine release and things like that, you're going to help to limit inflammation and limit pain, as it turns out. So for instance here, you know, if you can limit the release of things like substance P, prostaglandins, all of that helps to prevent the pain fibers from being sensitized and being sort of hyperexcitable. If you can help to limit that, it's going to decrease the amount of pain signals being transmitted up into the brain. So here's what it would look like, say, from a site of injury. So say there's a cut or something like that. You can see all these nerve fibers being affected by inflammatory cytokines like substance P, as we mentioned, and prostaglandins. That then causes these fibers to be more likely to send pain signals, and then we'll go up through the spinal column, which is where we're going to find our opioids primarily work, and then travel up into the brain where it says, ow, that hurts. Maybe you should not do that again, or whatever the case may be. And so we'll find different medications work at different levels here, right? So we've talked about NSAIDs before in terms of rheumatoid arthritis. You're going to know those work locally versus, say, something like an opioid is going to be working more centrally. And so that's why we can get synergy between different classes of meds, is because they're working at different areas to deal with those ultimately painful signals. Now, when managing pain, there's three main types. There's somatic and visceral pain, which is more so actual like tissue injury, um, versus neuropathic pain, which is more of a nerve issue. And you're going to find these are treated pretty differently. Whereas somatic and visceral pain, so someone breaks an arm, things like NSAIDs, acetaminophen, corticosteroids can be useful. And then we're going to talk about our opioids primarily today. And then with neuropathic pain, you're going to see here that we're going with different agents, usually things that are going to help out with decreasing the excitability of those nerves. Now, we'll cover the neurology meds next week after your exam, but we'll talk about some other agents we can use here and get into things like antidepressants and muscle relaxants and all of that. And then sometimes opioids will be used, but in general, if you can avoid using opioids, that's a good thing. It may sound like I'm not really concerned about job security, but overall, if you can use fewer opioids for your patients, that's going to be generally beneficial. A lot less side effects. Savannah's asking, generally speaking, is post-op pain considered neuropathic or somatic or visceral? Typically, it's more of a somatic visceral sort of issue there. So, for instance, if you have, say, like open heart surgery, just for instance, like you're cutting through a lot of bone, a lot of that tissue, cracking open those ribs, like a lot of that's all somatic and visceral pain the patient's experiencing there. So in general, surgery is going to be more considered that. Neuropathic pain, you want to be thinking more about things like trigeminal neuralgias, diabetic neuropathies, fibromyalgia, multiple sclerosis, things like that are generally more nerve issues that you'll see with your patients. So that's more neuropathic, and so we'll talk about things to help manage that. In general, you're going to find that sort of your process for treating acute versus chronic pain, as I mentioned, is going to be a little different there. When dealing with chronic pain, you have to consider both physical issues, because generally speaking, chronic pain, you're going to be losing some degree of function, either their ability to get up, walk around, or do the things they want to do, or go to work. You have to deal with that too, right? So things like physical therapy are super important to get on board. Now, do a lot of people want to do that? Well, no, because it hurts and it's hard work. So a lot of people don't, but that's important. It can, to involve as well. Deal with any kind of psychological or behavioral issues at the same time as you're treating their pain. Because generally speaking, opioids do not have any evidence to show that they, actually treat chronic pain. They deal with painful sensation. They may not feel as bad, but they don't do anything necessarily to help treat that or cure that pain, right? So this is why you have to do things like all the non-pharmacologic methods and get those involved as well. And hopefully our goals here are to try to increase quality of life, get their ability to be functional again, regain independence. Those are things we want to shoot for there. Okay. So we'll kind of talk about our primary analgesics. We'll touch on acetaminophen and our NSAIDs, which we've covered previously, and then we'll get into our opioids, which will be the kind of the bulk of this topic today. And then also some of our adjuvant medications that we can use to help manage that pain. This will probably end a little early today, so if you have questions for the exam, please get those prepared. We can cover that and do like a little mini review if you like, since next week will be your first test. So just FYI, hopefully that's not surprising anyone. But anyway, so starting off with acetaminophen, this is sort of the bottom rung of the analgesic ladder. This is sort of the wimpiest out of the bunch, but it's a pretty standard thing. Most people probably have this in their medicine cabinet. It's used for all sorts of pain. It's and generally well tolerated. That's why we like it, even though it's not the most effective medication for pain. It's a useful adjuvant, meaning you can use it in addition to a lot of other things. And it's again very few side effects that people are going to experience here. So that's why it's usually used first line for all sorts of things, especially chronic pain like osteoarthritis, low back pain, things like that. For more severe pain, so for instance, if you had someone come into the ER and their femur sticking out of their leg and you offered them some Tylenol, they're probably not going to be too happy with you as a provider since they're experiencing 10 out of 10 pain. Tylenol is not going to touch that. However, though, you can find some cases where Tylenol can be useful because they can have what we call opioid-sparing effects. And so as just an example, there's an IV form of Tylenol that's available that you can use when patients are maybe going to the OR, or if they're NPO for whatever reason, you can actually use IV Tylenol, and that actually helps to reduce the number of opioids you have to use. It's been shown in trials. So that can be very beneficial. Again, fewer opioids is generally better, as we'll see here. So it doesn't really work for the local inflammation. So for instance, if I sprain my ankle, Tylenol is not going to do anything to the ankle necessarily and the inflammation there. Because remember, it's an antipyretic and analgesic, but it's not anti-inflammatory like an NSAID would be. It kind of works more centrally, even though we don't really know the full mechanism for why it's why it causes analgesia, but we just know that it does. But so it doesn't work at the site itself, as I mentioned, more centrally speaking, but also doesn't have a lot of systemic side effects, as we'll see here. So we don't have to worry about bleeding issues. We don't have to worry about respiratory effects, things like that. The one thing, obviously, we do have to worry about is the liver, and you definitely don't want people to exceed their 4-gram limit per day. And again, this is for typical healthy patients who have normal liver function. This amount will be reduced for patients that have issues of hepatic dysfunction, chronic alcoholism, cirrhosis of the liver, hepatitis, things like that. Those patients should be getting lower doses, if any at all. Again, because you can see, transaminitis and hepatotoxicity from that. So I'd be very careful there. A really important teaching point here is to consider all sources for the acetaminophen, because you'll find a lot of opioid products will also contain Tylenol. There are a gazillion over-the-counter products that contain Tylenol, so you have to make sure that you're taking into account every source they're getting, because it's very easy to go over that 4-gram amount. So if you can consider someone who is on Lortab, which is hydrocodone and acetaminophen, they're taking that every 4 hours, and then they're taking OTC Tylenol outside of that, because again, they have access to it. People can take it if they've never been educated appropriately. And they're very easily over their 4-gram limit. And so if they do that for several days or weeks or months, you can certainly cause a lot of damage to the liver. Okay. So be careful with that. A lot of the packaging nowadays, make sure that all over it says contains acetaminophen, because they're trying to make sure people understand that. But again, if you only know, say, hey, make sure you don't take any extra Tylenol. They say, okay, I can't take Tylenol, but I can take this acetaminophen. They may not equate the two words together, and so that's your part of your job as a provider, is to make sure that they're educated on that they know, okay, these two things are the same thing. I can't take any extra, right? Sounds silly, but if you're inundated and if you live this life, then you think a lot of things are very obvious, but to your patients it may not be, right? Now, NSAIDs are going to be helpful for inflammation at the site itself due to its ability to decrease prostaglandin synthesis by inhibiting cyclooxygenase. We've touched on this briefly in rheumatology, where NSAIDs are sort of the bread and butter sort of therapy for those patients there. But we'll get into a few more details in terms of a few different NSAIDs that maybe we haven't covered previously. Certainly NSAIDs, I would include aspirin in this case here. I probably wouldn't use aspirin for a lot of chronic pain in terms of side effect profiles. Aspirin you're going to find a lot worse than the other NSAIDs, especially if patients are taking too much of it. So I would generally say, maybe occasionally, but I would prefer patients use NSAIDs in general over aspirin in a lot of cases there. Obviously, aspirin is going to be sort of different from the other NSAIDs because of its irreversible properties, which is why we like it for things like cardiac protection, due to its effect on the platelets and how its bleeding risk is higher because of that. But in general, you're going to find that most of your bread and butter NSAIDs for pain are going to be things like your ibuprofens and naproxens, which you'll find over the counter. And then we'll talk about a few other ones, things like ketorolac or Toradol, Tolmetin, indomethacin, things like that. There's no benefit of one over the other, so in general, you'll find patients may respond differently depending on the agent you're using. So if they don't respond well to ibuprofen, doesn't mean they're not going to respond well to something like Tolmetin. So you can switch around and find out what they prefer. A lot of dosage forms available, so you can use IV, IM. We'll talk about kind of our go-to parenteral NSAID, but certainly things are available if need be, depending on the patient's state there. And then typically we trial it for 2 or 3 weeks, see how the patient does with it, and then kind of move on if it's not really cutting the mustard, so to speak. So I think that's the term. Anyway, our issues here with NSAIDs you're going to run into, especially with chronic use. We talked about the gastric and intestinal ulceration that can happen here. Recall this is more of a problem with non-COX specific NSAIDs, which most of them are going to be non-selective, so they're going to affect COX-1 and COX-2 equally. So you're going to find that you can decrease that protective barrier that we have that protects the stomach from digesting itself, basically. So if you recall, prostaglandins help to stimulate the mucus and bicarbonate secretions that protect the stomach. If you inhibit, and primarily it's COX-1, that constitutive enzyme that is normally helping to produce the prostaglandins and make that barrier. So if you inhibit COX-1, which most NSAIDs do, you're going to decrease that mucus production and thus can lead to ulcerations. That's one of the big things with chronic use we worry about. You can also see bleeding risk. This is more so with aspirin than the other NSAIDs, but as long as an NSAID is in the system, there is a little bit higher propensity for bleeding. So that's one thing you want to know, especially if patients are going to surgery or something. And then other issues, we will typically avoid using NSAIDs in late stage pregnancy, so like the third trimester, because it can have some issues in terms of fetal effects. It can delay spontaneous labor, things like that. So we'll talk about pregnancy in the OB-GYN section later on this semester. So we'll talk about pain specifically there. There are some patients who may be more predisposed to developing asthma attacks as a result of use of NSAIDs. This has to do with inhibiting the COX pathway and how that shunts things or arachidonic acid over into the lipoxygenase pathway, and that causes leukotrienes to be formed, and which we know from talking about pulmonology at the beginning of this semester, that causes bronchoconstriction. So more leukotrienes means more bronchoconstriction, means you can have an asthma attack. So if you ever hear someone say, "Oh, I have an aspirin allergy, an ibuprofen allergy, made me have an asthma attack," that's what they're talking about. That's the kind of a reaction they're getting. Not true anaphylaxis, but it can look like that since they're complaining of shortness of breath. The other big thing I'd worry about with NSAIDs as well is renal function, especially for patients who have renal disease. Oftentimes they're really dependent on those prostaglandins to keep their afferent arterioles open in the kidneys to make sure they have blood flow coming into the glomerulus to have filtration occur. If you give those patients NSAIDs, they will then clamp down on those arterioles and thus less blood flow is getting into the kidneys. And that's why NSAIDs can cause acute renal dysfunction or acute renal failure in some cases for patients who are predisposed to that. Now, like a healthy 20-year-old, not going to be an issue. But if you have like a 65-year-old diabetic patient with diabetic nephropathy, yeah, that can be a big issue for them. So that's something to consider there as well. So in general, most of our NSAIDs fall under the category of propionic acid derivatives. That just more has to do with their chemical classification. But again, I'm going to lump all the NSAIDs pretty much together, but this is just the biggest group here. Most of them will be available orally. They have pretty good bioavailability here, and most of them will undergo hepatic conjugation. So again, if you have hepatic impairment, you may see some slowed metabolism, which may lead to some side effects there. And then again, we're going to look at some ones that help us to develop less GI side effects. That's going to be based on some of their selectivity for different COX enzymes. We'll get into that in just a little bit later. But of course, we know we use it for all types of pain. So again, this is a step up from acetaminophen in terms of analgesic activity because it does work locally at the site of inflammation and injury. So we have things like ibuprofen, naproxen, which most people are familiar with. These are the over-the-counter varieties. Then things like ketoprofen, phenoprofen, flurbiprofen, and then oxyprofen. The main differences between these are going to be things like how often you have to take them based off of half-life. So for instance, if someone has like chronic pain, they can go on something like oxyprofen, but they don't have to take it one time a day, right? That way it helps out with compliance, and in addition to all the other medications they may be taking, it makes the regimens a little bit more simple. Versus if it's like someone has a headache and they just are, it's a very acute sort of thing, a dose of ibuprofen is probably going to be fine for them because it's not more of a chronic issue. Other things we can see being used include things like indomethacin. This one has a little bit higher incidence of side effects, which is why you may not see it used as often, including things like hematologic toxicity, meaning like bleeding risk and things like that. Keep in mind, most of these NSAIDs are going to decrease the effects of diuretics, and that has to do with those kidney effects and decreasing prostaglandins in those arterioles. That's one thing to consider as well. And some of these you'll actually find they only recommend being used for very short-term use because of their effects on the GI tract. So for instance, indomethacin, you wouldn't want to use this chronically all the time because of the GI issues you can run into, right? We know some ways we can get around that, right? So you can give them like a PPI in addition to the NSAID or something like misoprostol. So there are some ways to get around that if you have to use it chronically, but we'll look at some other options here in just a few moments. Another interesting use for indomethacin is actually in neonatology. So if you have patients who are born and they have a patent ductus arteriosus, so basically it's a hole between vessels that allows for fetal blood flow to happen naturally when the fetus doesn't need to breathe, basically, because they're still in the mom. Once they're born, this is generally supposed to close, but you'll find that in some cases it doesn't. So what we can do for those patients is actually give them an NSAID, and it decreases the prostaglandins that are keeping this open, and that causes that to close down. So it's chemical ligation of the patent ductus arteriosus. If that doesn't work, then sometimes I'll have to go in and surgery, but if we can do chemical means, that is beneficial. Okay, next is Toradol. This is going to be like a workhorse NSAID if you work in the ER, urgent care sort of setting. This is a really like go-to parenteral NSAID. You can use this all the time, and so this is like kind of your go-to IM sort of NSAID here. So very beneficial because it's sort of like just a step down from a lot of your opioids, and will help to maybe in some cases reduce the need for opioids, which can be beneficial. And it's opioid sparing as well, so you can use it in addition to opioids and maybe need less of them in general, which is great. I apologize if you hear the door rattling. It's my 3-year-old trying to come in. But other things to look at as well is you're going to find that this has pretty nasty GI effects, and so we actually limited this to no more than 5 days worth of use. So if you have more than 5 days of use of this, then you can increase your risk for GI toxicity. So in most places, they have an automatic cap on this. So for instance, if someone comes out of surgery and they've been written for Toradol, the system will put an automatic stop on it after 5 days. Some places will do 3, but most places will do 5. So that's one kind of unique things about this, is because it can be so potent in terms of its GI effects, that's why you cannot use it for more than that. Some other ones include things like piroxicam. This one is going to, being, used more chronically, probably because of its kind of more mild GI side effects, as compared to some other things like indomethacin and things like that. So that's why piroxicam is sometimes used. Meloxicam, this one's actually kind of interesting because this one is the first one we're looking at here that has some selectivity for COX-2. As we mentioned, COX-1 is responsible for that GI barrier we talked about. COX-2 is the inducible kind. That's the one that gets ramped up in cases of inflammation and injury. So ideally, you'd like to have activity against just COX-2 because that's what is mainly causing the pain there. We're going to find there's some issues with that. And so if you inhibit COX-2 exclusively, you actually lead to more death, as we'll see here in just a few moments. But some selectivity can be useful because it helps to limit some of the GI toxicity. So if you have a patient with, say, rheumatoid arthritis who have a history of GI issues with NSAIDs, this may be a good one to try for them because it helps to sort of limit that. Next, we have nebumetone. This one also has a little bit of COX-2 selectivity there. Again, pretty well tolerated. You'll find this one, it gets used for rheumatoid arthritis and osteoarthritis pretty commonly. And then diclofenac. This one's good because it actually has a topical formulation available that's over the counter now. It's a fairly recent development. So patients can go and buy this topical Voltaren gel, just apply it to the site of injury. Now, this is good if you only have like, a limited number of places that are injured. So for instance, if you have like osteoarthritis and it's just 1 or 2 joints, that's great. If it's like more systemic pain, then that's going to be an issue because you don't want to slather up your whole patient in Voltaren gel. That wouldn't make a lot of sense. And obviously you don't want to put it over like, if you cut yourself or something, you wouldn't want to put the gel right over that because that could lead to irritation and too much absorption of the stuff. So really for like intact skin, limited areas, but for some people, if they just have like knee osteoarthritis, this can be really helpful for them. So that's why we like it. And you'll probably see it used topically most of the time. Now, getting into specifically COX-2 inhibitors, we find this is good for patients with high-risk GI histories. However, there were a few agents that came out that were like just exclusively COX-2 selective. And unfortunately, they actually found there's an increased risk of heart attack and stroke. It has to do with the balance between prostaglandin and prostacyclin synthesis and how that has effects on things like blood pressure and blood vessel development. And unfortunately, what we found was is that by exclusively using drugs that focus on COX-2, that does lead to increased risk of death. So, and again, that was something that was a pretty big deal because, the drug, when it came out of clinical trials, clinical trials only look at thousands of people. You don't find 1 in a million side effects like that. Or is rare. So when it came out and it was touted as being this like miracle drug that was great for patients with chronic pain because it didn't hit the GI tract, a lot of people started taking it, and that's when they started to notice the risk of death and actually got taken out of the market. So things like rofecoxib and valdecoxib If you ever hear like Vioxx, you can look up some controversy about that. That was just taken straight off the market. So nowadays, though, we do have celecoxib, which is probably as selective as you can get without causing this increased risk of death. So celecoxib or Celebrex is kind of the one that we still use nowadays. That's why I have it bolded here. All these other ones have been removed. Etodolac is sometimes used. I see this more used for like veterinary purposes. If like a dog with arthritis, I've seen that used occasionally. But celecoxib or Celebrex is primarily the one I see used for most human patients. Not to say you can't see Lodine being used in humans, but I just don't see it as often. So Celebrex is used, again, for people with high-risk GI history. And again, that selectivity is not absolute. It doesn't only affect COX-2 because, again, that's when we saw that risk of death. But it's about as selective as you can get without causing any sort of heart issues. Okay, that's it for our NSAIDs. Moving on, now we can talk about our opioids. The opioids are basically compounds that either are naturally occurring or derivatives of, or sometimes nowadays you have fully synthetic varieties, but basically agents that bind to opioid receptors. And most of them got their start, or at least a lot of them, are derivatives from the poppy plant, right? So here's an example of what the poppy plant looks like. If you ever heard of like opium, that's derived from the poppy plant. And basically, opioids is just anything referring to something that binds to and activates opioid receptors in the body, right? Now we have these natural receptors because of things like, endorphins and enkephalins and things that naturally bind to them. If you ever heard of someone having a runner's high, that is something where the body's naturally releasing compounds that interact with those opioid receptors to cause some degree of analgesia and a little bit of euphoria. I'm primarily going to be focusing on the mu opioid receptor. There are kappa and delta as well, but for our purposes, they don't come into clinical consideration as much. So just the mu is what we're going to focus on here. And these are going to be better for more moderate to severe pain, right? So if someone comes in, they have that femur fracture, they're probably going to be getting some IV opioids, and that's appropriate because that's for very severe pain. How these work, you're going to find that, say you have injury, that's going to be sending painful signals up through the spinal column. This is the first place where our mu receptors are going to lie, where our opioids can help to blunt that signal from traveling up into the brain. So it kind of limits the severity or the number of signals reaching up to the brain. And then you'll find the opioids also kind of work secondarily in the brain itself in order to help kind of limit the sort of, the pain the patient's experiencing. Someone's described it, I've never experienced opioid effects to any degree. And so someone described it as, I still knew I was in pain, but I didn't really care about it, right? So it helps to limit that quite a bit. This is also in the brainstem as well, as we're going to be seeing a lot of the respiratory effects that we are really concerned about with overdose. We'll talk about that briefly here in just a little bit. So as I mentioned, mu receptors are really important for their effects in both the spinal column. Also, this is where you're going to see the mu receptors are going to be responsible for the analgesia, also the respiratory depression, and then also the euphoria. So when you think about patients abusing opioids for their euphoric effects, it is the mu receptor that they're mainly utilizing there. And again, that helps to activate that mesolimbic system, that dopamine pathway that causes addiction, right? So people receive this, especially if they're kind of predisposed to it, either genetically or otherwise, and they have that dopamine hit. They really like it. They want to go back to it. That's what can lead to sometimes that cycle of addiction that occurs there. Again, kappa and delta have their places, but I'm not really going to focus on it here too much because clinically they just don't come up that often. So you're going to find that different drugs here may act as either agonists, maybe they're partial agonists, and we'll also look at antagonists as well. This is going to be important because we got to have a way to reverse these drugs. If a patient's having too much effects, we'll talk about that, but primarily we're going to focus on the agonists. These are the most common ones that we'll see. So a couple of things to talk about that we haven't really touched on yet are going to be chemical dependency, addiction, and so I want to make sure we kind of properly define some of these terms here because it's very easy, but you've never dealt with it personally, to not understand sort of the differences between things like tolerance and physical dependence and addiction. I think a lot of lay people especially sort of kind of lump all these in together, and so they just think, oh, this person's addicted, or if I take opioids, I'm going to become addicted. That's not usually the case, but we'll look at some ways we can try to differentiate between these, and hopefully you can educate your patients on this as well. So with physical dependence, this is a normal thing. This is going to happen to anyone that takes opioids chronically, right? So if you have like maybe 3 or 5 days worth, probably not going to be an issue. But if you're on it for months and years, you're going to develop physical dependence. This is not addiction, right? This has to do with the body getting used to the opioids and getting a new sort of homeostasis, a new set point for normal for the body. And so because the body's used to having that around, when you have cessation of the opioids, you're going to have the body reacting against that, right? So you disrupt homeostasis, your body doesn't like that. And so that's where you get a lot of withdrawal effects, right? So just because someone has withdrawal from opioids doesn't mean they were addicted. It just means they had physical dependence on the drug. Their body's just used to it being around. So this is why you can get things like nausea, vomiting, sweating. They're going to be miserable. It does not feel very good. Now, a lot of times this can lead to those cravings, and oftentimes people may go back to opioids because the withdrawal effects are so severe that they are going to find any means to help mitigate that, right? So that's why some reason why people will fall off the wagon, so to speak. If they're trying to quit opioids, they'll go back to them because of these withdrawal effects. However, this is not fatal. No one's ever died from opioid withdrawal. They'll probably wish they were dead because they feel miserable enough, but they will not die from this. Okay, they'll be, in stark contrast to something like benzodiazepine withdrawal or alcohol withdrawal, which absolutely can be fatal, can lead to seizures and things like that, but not opioids. Again, this is frequent and expected, not correlated with addictions. That's physical dependence specifically defined there. Addiction, on the other hand, is more of a psychological dependence, right? This is more of a behavioral sort of issue here where they start to have sort of impaired control of drug use. They are compulsive in terms of their use, and they have continued use despite harm, right? So this is seen with like drug-seeking behaviors. You'll see patients will make decisions in terms of, should I pay for my electricity bill or should I get opioids? They're making poor decisions because they have the psychological dependence on the drugs there. And so this is sort of kind of a succinct definition, but again, not everyone who starts opioids will become addicted. And some patients are worried about that. And so you can tell them, hey, while we don't know the actual risk, most people will not become addicted if used appropriately. Okay. Now, tolerance is another thing we're going to see that happens here. And basically, this is where patients get used to the effects of drugs over time. So it appears the drug effectiveness is diminishing, but it's really just the patient getting used to it. So they'll have tolerance to the analgesic effects and some of the side effects. So things like sedation, which is pretty common with patients starting opioids, is going to be sort of mitigated over time. So people can be on huge doses of opioids they've gotten used to over time, and they can have a normal conversation like I am right now, right? However, some things you will not develop tolerance to. Things like constipation is going to be ever present with people on chronic opioids there. Now, sometimes they can develop something called pseudo-tolerance, where it's not necessarily that the patients have, not necessarily that the drug is less effective. It's just that their pain state is now increased. So maybe they're able to get around and do things more often. They are being more active, and that leads to a change in their pain state. So now all of a sudden their pain level has risen, and the opioid dose has not risen to catch up with that. So it's called pseudo-tolerance sometimes. Jillian's asking, how long would the withdrawal symptoms last? And that really depends on the patient. It depends on how long they were using it for. It can, sometimes you think about like detox centers where, patients will go in, say, for 28 days. And they'll go in there, they'll detox, they'll be, pretty miserable for that time frame. And then ideally when they get out, they say, okay, now you're good to go. You've got the opioids out of your system, and you can go and be, have your sobriety. Unfortunately, though, again, a lot of that does not deal with the psychological dependence, right? So a lot of issues that come about from that. So that's why, getting off of opioids is so difficult. Not just the physical cravings, but it's also the psychological sort of cravings there. But yeah, you can at least expect it to be several days in most cases, but a lot of that depends on how much they're using it for how long. So a poor answer for your question, but that's the answer you'll find there. Pseudo addiction kind of goes along with pseudo tolerance. Pseudo addiction is sort of patients experiencing or expressing behaviors that seem like they're drug seeking, and you may lead the provider to think that the patient has illegitimate concerns for pain or is trying to seek opioids out when they don't really need them. This is either due to things like under treatment, where the patient doesn't have their pain controlled correctly in the first place. So say, for instance, you write a patient for, say, 30 days worth of pain medication. They have chronic pain, you write them for 30 days worth. but they come back 2 weeks later and they say, I'm all out of my pain medication. You say, well, what happened? I wrote you for a whole month. But if their pain wasn't treated effectively, then they might have been self-dosing. They might have been taking more than what you had written for in order to get their pain under control, right? Because again, they're in pain. They wanted something to take for it, so they did it. That may look to you, and some providers look like they're just using it for euphoric purposes, or they're selling it, or whatever the case may be. So it looks like they have a legitimate need for more opioids, when really it was a true issue they had there. Now, again, can you tell the difference between someone who is expressing pseudo addiction versus true addiction? No, and if you could find out a way, I'd love to know, because you'd probably be, again, very rich if you could do that. Patients are very good at lying when they want to. Patients can express pain very convincingly. So it's very easy to get into a mindset where you just assume everyone is lying all the time, which is a pretty cynical mindset, which I would encourage you to avoid, and try to take patients, try to meet them halfway in terms of trying to elicit more history from them, get an idea of kind of where they're at, get their use history, things like that, and hopefully kind of get some more details and try to determine whether they have actual issues or they're just trying to seek out more medications. Because you'll find a lot of providers will just say, I'm just never going to use opioids ever. And they just shut that out completely. And depending on where you work, that may be appropriate. Like if you're in Durham, you probably don't need to use opioids ever. But if you work in the ER and you say, I'm never going to use opioids, that's going to be a lot of people that don't get treated appropriately because of that decision. So again, it can be a very tough thing to see whether you get your pain treated or not, depending on which provider you saw, which is kind of unfortunate in some cases. And pharmacists will do this too. You'll find some old school pharmacists who just say, I'm never going to give out an opioid, I'm just not going to fill it, and that's pretty inappropriate in some cases. So anyway, typically you're going to find that patients, once they get their pain under control, they will then gain function. People with addiction typically lose function over time. They can't keep a job, or they have their kids taken away, or they basically lose function due to their constant seeking out of these medications and opioids. So that's kind of one of the big differences. But again, it can be very difficult to tell when you're just seeing someone for the first time in the ER, for instance. Again, physical dependence is expected for every patient on chronic opioids, but addiction is not guaranteed. And again, that rate may vary depending on the population. And again, if you could predict who's going to be addicted and who isn't, that'd be great. But unfortunately, we don't have a means to do that right now. There's something in Florida called eForce. Most states do have a system like this, and this is a very handy thing that I would encourage all of you to sign up for once you have your license. Some of you may already have access to it already if you're a scribe or something like that, or MA. This is available for pretty much most healthcare providers in Florida who can sign up for this. And it basically, every time a patient fills for a controlled substance, whether it be narcotic, like opioid narcotic, or it could be ADHD medications, things like that, it will get logged in this eForce. And so basically, you could look someone up, and again, you should only do this for patients you're taking care of, not like a significant other, or your enemies, or whatever the case may be. Obviously, that's a HIPAA violation, but you can look up patients and see where they filled, how much they filled for, and all that information there. So it's very helpful, because if you have someone who you suspect of illegitimate pain concerns and are just seeking out medications, you can look up their record. And if they just had filled 200 oxycodone last Friday, and now they're seeking out pain medications, you can take that printout to them and say, okay, well, what happened to all these pain meds, and they may change their story pretty quick, right? Other times you'll find that they have a normal filling history, and it looks like they just have either change in pain state or something like that, and they have legitimate concerns, right? So it's a useful tool to help you decide whether or not you think someone has legitimate issues or not. Again, it's not foolproof, but it is helpful. And again, this is available in Florida. It does not communicate with other systems, unfortunately. And so wherever you go, whatever state you practice in, will likely have this something like this available. This is the Florida one. So again, because we're in Florida, this is going to be more Florida centric, but there was a bill passed back in 2018. This is a big deal. Again, Florida's kind of slow in terms of catching up with the times, especially when it comes to advanced practice providers getting the same sort of abilities to practice like they do everywhere else in the U.S. or a lot of other places in the U.S. And so this was a bill that came out. And again, there's a separate bill that came out that was mainly focusing on the ability for PAs and nurse practitioners to be able to prescribe controlled substances. Before, it had to either be like, a physician that was doing it, or you're doing like a hospital DEA license or something like that. But so a law came out probably like a year before this one that said, okay, PAs and MPs can do this with certain training and certain restrictions on it. And then House Bill 21 came out that was really trying to curb how much opioids were being prescribed for acute purposes, right? So before, you could just write 30 days worth of oxycodone for acute, someone that's spraining their ankle, right? Nowadays, it has changed, and so some of the things you have to do is include certain training. You have to do certain CEs you have to do for licensure, and then you have to make sure you're checking E-Force before prescribing any controlled substance, which again, how that is being enforced, I don't know. Probably not likely in a lot of places. And then for acute pain, so someone coming into the ER saying, ouch, I broke my arm, you can write for a 3-day limit. Okay, so 3 days worth of pain medication. Again, opioid pain medication, most likely. NSAIDs, you can write for as much as you want. These are for controlled substances. You can write for a 3-day limit, and you can extend that to 7 if you write acute pain exemption on the prescription. Okay, so you can write up to a total of 7, but 3 days is sort of the normal. And then if it's a chronic pain issue, then you just write non-acute pain on the prescription, and then you can write for the typical amount that you can for controlled substances. Well, I'll get into that in just a moment. So that's kind of the big changes that have happened. That was in 2018, so it's kind of standard practice now, so you won't really know any difference. But if you see things like acute pain exemption or for non-acute pain on a script, that's what it's there for, is to try to make sure the day's limit is going to be there. And so pharmacists are checking that, and they can bill the appropriate amount based on what you've written on your script. So, and again, we've talked about controlled substances before, so just recall that, for, there's C1 through 5. C1s are things that don't have any medical use, so things like heroin, for instance, is a C1, so that's never going to be prescribed. But C2s have the most tight control on them. Most of the opioids we're going to talk about today are going to be C2s, which I'll talk about. And again, those have the tightest control. You can only do up to like 3 months worth. You can't do any refills. Versus C3 through 5, you can write up to 6 months worth in terms of refills. You can do, the original fill plus 5 refills, basically. So that's kind of the big differences. Because remember, normal scripts are only good for a year. C3 through 5 are good for 6 months, and then in terms of refills, and then C2s you cannot refill at all. Okay. So the first one here is going to be codeine. This is again, pretty wimpy. I would put this on par, but with some of the NSAIDs in terms of pain control. This is frequently compounded with Tylenol. That's why you call it Tylenol number 3. There's like Tylenol number 2 as well, but Tylenol number 3 is kind of the most common one. And so this one, codeine itself is not a very good analgesic. However, it does undergo metabolism by CYP2D6 and gets converted to morphine. And so that's going to be much more effective for treating patients' pain. Most of you have heard of morphine before. And so you can find that some patients may be deficient in this enzyme, and some people will have more hyperactive versions of this enzyme. And so that means that some people who can't convert it over to morphine don't get very much analgesia, and they're going to say this is a bad drug. Versus some people have way too much enzyme activity, and they're going to convert a ton of it over into morphine, and they'll get really good pain control out of this. Unfortunately, the issue is that there's been cases where, and there's a CYP2D6, a black box warning for this, for especially in kids, how certain kids were actually undergoing surgery for TNA, so they had their tonsils removed, and they basically had, they're converting too much of this over into morphine, and they ended up developing respiratory depression, and they died in their sleep, basically, because again, their airway's kind of swollen because of surgery, and then they had all this extra morphine, and they died because of that. So that's why basically we don't use this in peds anymore. We took it off of our formulary. Most other places did as well. And in general, it's kind of fallen out of favor. You're not going to see a whole lot of codeine use anymore. But for some people who they respond well to it, they love it, and that's all they're going to use. This is typically like a C5 or C3, so kind of showing you how it's kind of on the wimpier side of things versus a lot of your other opioids, which are generally C2s. Now, morphine is like a tried and true go-to sort of opioid. You'll find this used for chronic pain from an oral standpoint, and you'll also find it used IV for more acute use in the surgery setting, in the ER setting, things like that. So if you look at the oral forms, you'll typically find like immediate release formulations used for acute pain, and then extended release forms used for more of the chronic pain, right? More of that basal control of pain throughout the day. So if you ever see that MS Cotton, that is the extended release formulation. This one does have some metabolites, and so this is important to consider for elderly patients that have renal failure. They can build up levels of these metabolites. They can actually lead to, does lead to more analgesic properties, which can be good, but also can lead to side effects like the CNS and respiratory depression. Okay, you always want to be careful with drugs that suppress the CNS in elderly patients because it can exacerbate things like their Alzheimer's or their dementia and things like that. So it's one thing you want to be careful with. Another issue with morphine you're going to run into with some regularity is that it causes histamine release. And so this can cause a lot of itching in patients. It can also cause vasodilation, meaning patients' blood pressure can drop as a result of using morphine, especially IV morphine. And so some patients will say, "Oh, I have an allergy to morphine." They ask you what the allergy is. They say itching. That is probably not a true anaphylactic reaction. This just has to do with histamine release, and this is sort of unique to morphine and to some extent codeine because it gets converted to morphine. So in those cases there's some other agents we can use to get around that. So we'll talk about those examples in a moment. But if they have a true anaphylactic allergy to morphine, then we'll look at some different options we can use. Okay, so they just have the histamine issue. We can pretty much use any other opioid. For a true anaphylaxis, we'll look at which ones we can use specifically there in just a little bit. Okay, some patients you can pre-treat with Benadryl or another antihistamine to help deal with that. However, keep in mind most of those are sedating as well, so you can see too much synergy there. I would say just use a different opioid if you really need to. So hydrocodone is this used to be like the #1 most prescribed and probably still is pretty close to the top prescribed medication in the US. For a long time it was a C3, which means it had less control on actual prescribing of it. Now it got bumped up to a C2 because of how much it was being abused, and so that has curtailed its use because it has tighter control on it. This is generally found with acetaminophen, and generally is only used orally for the most part. So again, you'll see it used for both acute and chronic issues for these patients here. It does get converted to hydromorphone, which is another opioid we'll look at in a second here, which is Dilaudid, via that same CYP2D6. However, patients with more or less effective CYP2D6 enzymes, this is less clinically important than codeine. So you may find some patients respond better to hydrocodone than others. Some may have more side effects. It could be related to this, but clinically speaking, it's not as important as you would see with something like codeine. So it's just kind of a side note there that it does get converted over to Dilaudid. Oxycodone, everyone's favorite, OxyContin. I'm sure most people have heard of OxyContin. Florida was really notorious for a long time for being the first stop on the OxyContin Express. We used to have tons of pill mills that would send out huge amounts of OxyContin that would get distributed around the U.S., especially places like Virginia and Kentucky and places like that. You'd have these pill mills where you go to these strip malls. There'd be like a primary care doctor's office there, and the whole parking lot is completely filled with out of town license plates. You'd find people wrapped around the building waiting to get seen because they were giving these illegitimate scripts for just gobstopping amounts of OxyContin in a lot of cases. So not to say it's a bad drug, it's just that it has a lot of kind of notorious history associated with it. Anyway, so you'll probably see it's used a lot of times as a long-acting form, which is OxyContin, but you may also see it compounded either with acetaminophen or just by itself. So if you hear like Percocet, if you see that CET in the name, that means that it has acetaminophen in it. So Percocet, you'll see there with the Tylenol. This one also has some CYP2D6 interactions here with oxymorphone being the active metabolite, but again, clinically not as important. For some patients may not respond as well to it, right? So that's just something to note with that one. So, morphine, hydrocodone, oxycodone, those are kind of like your general, like oral opioids you're going to see probably most often, with morphine being pretty commonly used IV as well. So again, which ones you see most commonly are going to depend on your setting and kind of where you're practicing. Next we have hydromorphone. This is another good like IV one. You'll see it used orally sometimes for patients with chronic pain issue. I see this a lot in patients with like sickle cell disease. But we use this in IV all the time in the hospital. And so basically this is good because there's a shorter half-life than morphine. And so it allows us to kind of titrate it a little bit better in terms of if we're using either as a continuous infusion or if we're given intermittently, that can be useful. Note here that it has less pruritus associated with it, so it causes less histamine release than morphine. So if I had someone who had, like, say, low blood pressure or someone with a history of itching to morphine, I would probably switch them to something like hydromorphone. As long as I'm not concerned about a true anaphylactic reaction, this would be fine to use. If they did have an anaphylactic reaction to morphine, I would be cautious to use this because structurally they look similar enough to one another. You could have some cross-reactivity. It's not guaranteed, but it could happen. I'll talk about another agent we can use if they have a true anaphylactic morphine allergy. But this one, if they just have an issue with the histamine with morphine, just itching, I would use hydromorphone, no problem. I think some people kind of have like a negative stigma with it. They kind of think it's a little bit scary. It is more potent than morphine, so the dosing is a little bit different. But as long as you're used to the dosing and you kind of take that into account, then you'll be fine. So I'm seeing more and more providers starting to be more comfortable using Dilaudid. Next we have fentanyl. This one you'll see a lot used either like in the ER setting or in the surgical setting for sure. This is a fully synthetic opioid, meaning that it does not structurally resemble any of the compounds that come from the poppy plant, basically, right? So it does not look like morphine to the body or heroin or anything like that. So this is actually really good to use if patients have a true anaphylactic history of reaction to morphine or any other opioid. You could use this with no problem because structurally it's just so different, right? So if someone had a true anaphylactic allergy to morphine or hydrocodone or something like that, I would feel safe giving them fentanyl, and so that's very handy to use. It's also really much more potent than morphine. So, for instance, a typical dose of IV morphine being somewhere between 2 to 5 milligrams, a equal potent dose of fentanyl is somewhere between, like, say, 50 to 200 micrograms, right? So much, much more potent. You want to be very careful. If you were to give someone 2 to 5 milligrams of IV fentanyl, they would be dead. They would just stop breathing immediately, and you'd have to intubate them and all of that. So be very careful in making sure that your dosing is appropriate to the drug that you're using, which sounds kind of common sense, but I've had some issues with providers in the past that did not understand that, right? There's a lot of different dosage forms that are available for this as well, which is handy. So for instance, IV is probably the most commonly used, but you'll see for more chronic pain issues, you can do things like transdermal. So if you ever see like a Duragesic patch, that is a fentanyl-based patch. That's for good chronic pain because the patch will slowly release the fentanyl across the skin over the period of several days. Note that that's not good for acute pain because it doesn't have a fast onset because it takes time to sit there and trickle through the skin to get into the systemic circulation. You could also do things like transmucosal. So here's a picture of the fentanyl lollipop, they call it. So basically the patient experiences pain. They can take this, place against the inside of the cheek. Once the pain is relieved, they can then take it out, right? So it kind of allows them to titrate pretty easily there. And then even intranasal, I use, not me personally, but I use intranasal fentanyl for kids all the time in the peds ER because if they have a pain issue that is severe and they can't get an IV started just yet, or the kid's like really nervous and not wanting to get an IV started because kids are needle phobic, intranasal fentanyl works great. You can just spritz that up their nose. It's the same IV formulation, and they get good mucosal absorption and good pain relief from it. So that can be really handy, and it chills them out so you can get the IV started if need be, which is good. There's also a few congeners of fentanyl called alfentanil, sufentanil, and remifentanil. You'll typically find this used in the surgical setting most often, probably not in the ER as much. And again, these are good for patients who have true anaphylactic allergy to other types of opioids. Next, you have methadone. Methadone is classically known for treatment of opioid addiction. I'm sure most people have heard of like a methadone clinic before. Nowadays, though, we are seeing it being used for more chronic pain purposes. So you'll see not everyone on methadone has an opioid addiction. Some people are just on it for pain purposes, right? So one thing to note with that. The reason why we like this is because, one, it has a really long half-life. You can see here, more than 50 hours. So once it's built up in the system, it has a good long half-life. So that's handy for people who are trying to abstain from opioids and trying to maybe wean down off their dose, because this helps to prevent withdrawal symptoms, which is usually why people relapse anyway, is because of withdrawal symptoms, and trying to mitigate those. And it's also good for the chronic pain because of the long half-life as well. So someone may be on methadone, say, once or twice daily around the clock, and then they'll be on something short-acting for breakthrough pain like hydrocodone or oxycodone or something like that. Note it also has some additional benefits because it helps block reuptake of norepinephrine and serotonin. Serotonin's 5-HT. It's the abbreviation for that. And that is useful for like neuropathic pain issues. And so we'll see that just a little bit. So additional benefits from a pain standpoint. One thing to note with this is that it does prolong the QT interval, so I would want to make sure that patients' electrolytes look good, make sure magnesium and calcium are in check, and then in some cases you may want to check an EKG, especially if they're on other meds that can prolong the QT. So that's one thing to note there. Generally speaking, this one is can be difficult to work with. So generally speaking, you as a PA may not be writing for this super often. Maybe more like your pain management specialist and things like that, but you may run into patients who are on this and you still need to be able to work with that. But as time goes on, people get more comfortable with it. We'll see who's really using it. Another drug here called meperidine or Demerol. This is another synthetic opioid that almost should never be used for pain purposes, at least, because it does have a toxic metabolite that is built up in patients with renal dysfunction, primarily elderly patients. That can lead to things like seizures. So a lot of people don't like it from that standpoint, and so we typically do not use it for pain purposes at all. It also has a tendency to interact with a lot of your depression medications because it blocks the enzyme monoamine oxidase, which we will talk about later when we get into behavioral health. That can lead to a lot of interactions there, so that's one thing to know. The one place you're going to see this being used is in the case for rigors. So if you have a patient who is shivering, especially like in the post-operative setting, this can be used to help limit that. So sometimes in surgery you'll see it being used, but otherwise stay away from Demerol. Here's a good question. Someone says, what is a safe way to dispose of opioids? For example, the patient didn't use all the prescription, doesn't want to keep it in-house, or for whatever reason. Thank you. You're welcome. Couple ways you can do this. So one thing would be is that in some cases you're going to find that a lot of times like sheriff's offices will have like drug disposal days. And so this may be a case where like a patient has died and they have a bunch of opioids left over. That happens a lot with like cancer patients. They'll have like drug disposal days. Sometimes they'll set up at pharmacies, different places, but you can look them up like on sheriff's offices websites. And so they'll basically have the thing organized where you just come and bring it to them, drop it off, and then, that's it. And they'll dispose of it however they do. Generally speaking, you don't want to put stuff down the drain because we can find levels of that in the water after the fact. So generally don't do that. In some cases, you can do things like, if you want to like crush them up and put them into like kitty litter or coffee grounds or something like that, something to make it unrecoverable. That's another way to do it too. And then you just toss it in the trash. So a couple different things you can do there. But yeah, either like call up a pharmacy or call up like a sheriff's office, and they usually will have days where you can bring in opioids and get rid of them. That's a very good question. So thank you for asking that. Next, we have buprenorphine. This one is used exclusively for patients who are weaning themselves off of opioids for addiction treatment for substance use disorders. Whereas with methadone, we'll see it used both for pain and for opioid addiction. In this case here, buprenorphine is just used for addiction. The reason for that is because it's a partial agonist, and it has a really tight binding affinity with the opioid receptor. So purpose of this is that it will bind to the receptor really tight and then only partially activate it, meaning you're not going to get the full euphoric effects of typical opioids like heroin or oxycodone or things like that. So the goal is that it has enough activity to prevent withdrawals, and it also binds so tight to the receptor that if the patient did abuse something like methadone or oxycodone or something else, a full agonist, it would not be able to interact with the receptor as well, and they would not get the full effects out of it. Okay, so it's also used a lot of times as like a long-acting form. So sometimes it'll be used as like a transdermal product, as an implant, in order to help ensure compliance. Sometimes even compounded with something called naloxone, which we'll talk about in a moment here. And that helps to deter IV drug abuse if they wanted to inject the product. That's another concern too, is that patients will take oral dosage forms like pills, and they'll crush them up and try to inject them, and that can lead to some other issues too, because there's a lot of stuff in there that you do not want in your veins. But you'll see this used a lot for opioid addiction specifically. And again, this is something you can get your MAT training, medication assisted treatment training. You can actually do this before you graduate, and like 24 hours of education, and basically get a waiver. So when you get a DEA license, you can actually prescribe this. for opioid use treatment. Methadone, for that specific purpose, PAs can't write for methadone, at least in Florida, but for buprenorphine, you can get a waiver to do that, which is good. So generally speaking, again, you're going to be picking the agent based off of pain intensity, other pharmacologic factors, look at the organ function. And again, for persistent pain, you're going to be picking a long-acting form plus or minus a short-acting on top of that for acute breakthrough pain, right? Generally, oral is going to be used most often. For chronic pain, you can get away with transdermal things like fentanyl, for example. However, just note that like transdermal products are not good for acute pain because of the fact that it takes time for them to kick in because they have to trickle through the skin before they can actually work. And again, I like intranasal fentanyl from a standpoint of not having to use IV access, but you still get, pretty close to parental activity of the drug there, which is great. And remember, this stuff is going to be individualized, so start low and go slow and titrate as needed because, again, you don't want to give too much because you can't really take it back, but you can always give a little bit more if you need to. And now, again, I'm not saying if a patient comes in with their femur sticking out of their leg to start off with Tylenol and gradually work their way up, you can start off with the opioids, but again, you can always go with more conservative dosing, give more if need be, okay? In terms of adverse effects of opioids, constipation is going to be something you're going to see in like 100% of patients who are on opioids. We just know it slows down the GI tract. Sedation is another common thing you're going to see too as well, although patients do develop some degree of tolerance to this. So again, the sedation effect is normally seen with dose changes or new initiation of them. And we talked about the histamine release primarily being a problem with morphine and codeine. Less frequently you're going to see is things like altered mental status and respiratory depression. This should be relatively low risk when used by themselves and at normal dosing, but the problem is when you start to combine meds together. So a terrible trifecta of meds I see a lot of providers use is a muscle relaxant plus a benzodiazepine plus a opioid. We'll talk about benzos coming up next week, but that combo is just super sedating and has a higher risk for respiratory depression. So I can't tell you how many patients I've seen intubated while on that triple threat of drugs, and not because they were abusing it for any specific purpose, just because they didn't realize that the three would interact that strongly together. Especially add on some alcohol on there, it's no good. Also, risk for abuse and diversion. When I say abuse, this basically means people who are using too much or more so than what you wrote for in order to get that euphoric feeling. So it's one thing to consider there. People may be using oral dosage forms IV, which is obviously a big issue that can lead to things like endocarditis and PEs and all kinds of problems. And then the other big thing too is diversion. So basically taking opioids, or you're getting a prescription for opioids, filling it, and then selling those to get whatever your opioid du jour or whatever drug you like is. So they may sell their opioids in order to get cocaine, for instance, or whatever the case may be. This is also a problem with healthcare providers as well with diversion. We see that, especially with like anesthesia providers, sometimes pharmacy providers, they may be diverting medications either to use for themselves or to sell. And that can be a big issue too. So that's a big thing you'll see with hospitals is they do a lot of diversion monitoring. So they look for things like, okay, is the same nurse always getting the morphine for the patients? If someone's like, oh, don't worry about this, I'll go ahead and get the morphine for you, I'll take care of it for you, and then it's like the same nurse doing it all the time, we look at stuff like that to see if they may be potentially diverting. So ways to minimize these adverse effects includes things like titration. Try to determine like why they're getting the symptoms. So if they're getting really itchy and they're on morphine, well, that makes pretty good sense. You can switch them to something like Dilaudid, for instance. Look at changing the route or the regimen potentially, and then you can treat the adverse effects. So one of the things, as I mentioned with the constipation, is you always need to put these patients on a bowel regimen. So if they're going to be on for more than a few days, they probably need to be on some kind of laxative. So generally speaking, we go with a mush and push sort of mantra. That sounds kind of gross, but basically what that means is we're going to use a stool softener plus a stimulant laxative together. So typically like Docusate plus Senna is a pretty good combo there. We can also use some of our bulk forming laxatives, things like fiber and non-digestible fibers should be used as well, making sure they're getting good hydration. And then if still you need something else, then we can try using some of our osmotic laxatives. So things like, polyethylene glycol, Miralax can be used in addition. But at a baseline, they need to be on some kind of stool softener and most likely a stimulant laxative. But these patients get so backed up. And think about it too. Patients coming to you, they're on opioids, complaining of belly pain. A lot of times it's just symptoms of their constipation. They don't even know it. They don't realize, you ask them, well, when's the last time you had a bowel movement? And they say, oh, it was 2 weeks ago. Right? It could be problems. It can lead to hemorrhoids. It can lead to all kinds of issues. So really make sure that constipation is not an issue they're dealing with, and treat that appropriately. In terms of antagonists, things we can use to block opioid activity, this is where we get into naloxone, which is our primary antagonist. This is not something you can use orally, but we use it either IV, intramuscularly, intranasally. And this does reverse the effects of opioids because it kicks it off of the receptor, basically, and prevents it from binding. So you're going to find that when given like pretty big doses of this stuff for someone who's receiving opioid, they will have immediate reversal of their symptoms. And you can see sometimes within seconds of an IV dose, patient will go from being intubated, not breathing on their own, to sitting straight up, screaming at you, pulling out the tube, because it is that effective at what it does. Generally speaking, we don't want to induce withdrawal in patients because it's very uncomfortable for them. Generally, they're not great to be around because they're vomiting or defecating, or they're really mad at you because they spent all that money on those opioids that you just reversed. So that's not great. As long as your patient's breathing, though, that's really the big concern with overdoses. They stop breathing and they die. So if you can at least give them enough to where they are breathing, that is useful. And your nurses will appreciate you because they don't need them to be awake. They just need them to be breathing, right? So that's the big challenge with that. And again, we're starting to see more providers prescribing this with opioids to use just in case. EMS and police police are more likely to be carrying this nowadays too. Again, because this can save a life, right? And so and I know some providers are like, well, aren't we just giving them license to go ahead and overdose again and again by giving this stuff? But again, I think as a healthcare provider, generally speaking, you probably want your patients to live, right? And if they do have an issue with overdosing for euphoric purposes, maybe like get them some substance use help. That's my stance on it. I don't know if you disagree, that's fine. But you're starting to see more of a push towards prescribing, co-prescribing naloxone with opioids in order to potentially save someone from a fatal overdose. From that standpoint, again, these patients cannot give it themselves because they're going to be so sedate, they're not going to be able to administer it, unlike an EpiPen or something. So other people need to be trained on how to use it. So like other people around them, loved ones, things like that, can be trained on how to give this, so that way they can use it safely. Again, here's an example of an auto injector where it basically talks you through the whole process. You can sometimes use intranasal, just depends on how they want to use it. Savannah is saying, if someone had a true allergic reaction after IV administration of an opioid, could naloxone or naltrexone stop that reaction? It cannot, because think about the mechanism there, right? They don't get anaphylactic because of any interaction with an opioid receptor. It's more so your IgE is responding to the presence of that drug. And so, you would not have any reversal of those effects with naloxone. You'd still have the anaphylaxis you're dealing with, but it's a good thought. We do have a couple options that are available that can be used for peripheral use as an antagonist. These are good for patients who have maybe like undergone surgery and are post-operative. And one of the big things you worry about post-surgery is you worry about ileus, you worry about the bowels just not moving. And oftentimes that can be a reason to not discharge a patient because they haven't had a bowel movement yet. And oftentimes this can be exacerbated by the opioids. So in some cases, we can actually give a peripherally acting drug that just affects the GI tract without affecting the CNS, and that can help to wake up the bowels in order to move things along. And so this includes a couple of drugs like alvemipan, methylnaltrexone, and then naloxegol. So here are some other medications we can use for treatment of neuropathic pain. Some of these we're going to get into in more detail when we get into like neurology and behavioral health. I want to cover a few of these right here that we can use more commonly, some stuff that you'll see. So here's kind of the list of them. I'm going to get into them more specifically now because I want to make sure I have a few minutes to just go over any questions you might have for the exam here. In terms of antiepileptics, these again are going to be useful for things like MS, for things like fibromyalgia, any kind of neuropathic pain. These can be useful there and can include drugs like carbamazepine, gabapentin. Again, I'm going to get into the specifics of these in their own individual section. We get into the neurology section later on. Just know that a lot of these can cause sedation. So if you're mixing them with things like opioids or other sedating medications, they can see dizziness, they can see ataxia, they can fall. This is going to be common side effects until they get sort of used to it and they get sort of tolerance to those sedating effects. You can also use tricyclic antidepressants. This is used pretty often because of its ability to inhibit the reuptake of norepinephrine, which actually helps to modulate those pain fibers. Basically, modifies the signal so it's less likely to be sending that pain signal up into the brain. And so these are, gold standard for a lot of patients with neuropathic pain issues. It includes things like amitriptyline, desipramine, things like that. We'll talk about those more so in behavioral health because these actually started out as antidepressant drugs. You'll probably see them nowadays more so used for neuropathic pain, though. A lot of side effects associated with them, things like sedation, a lot of anticholinergic side effects like constipation. You see some cardiac effects from this. So again, they do have their side effects, so they're not completely safe. But we'll talk more about that in the behavioral health section coming up. Then we have local anesthetics. These can be really useful for neuropathic pain, especially if there's certain areas, like if certain trigeminal neuralgia or certain things here can be useful because basically these will prevent painful signals from being transmitted in the first place. That's how they induce numbness, basically, is by preventing sensation, those signals of sensation up to the brain. They do so by blocking sodium channels and preventing those action potentials from being propagated up into the CNS. And so we do this a lot of times for things like needle stick analgesia. So someone needs an IV placed and they're worried about the pain associated with that. We can put numbing cream on them. So that's called Imla cream, which is a mixture of things like lidocaine and prilocaine. Generally speaking, if a drug ends with cane on the end of the name, it's a local anesthetic. But you'll see a lot of times things like lidoderm patches or lidocaine patches can be very useful for neuropathic pain concerns, shingles and things like that. And then we also use these pretty frequently in the surgical realm, either as like an epidural or as part of like a local or a regional block. So say, for instance, someone has their knee replaced. By infusing these local anesthetics right at the site of injury or at the site of surgery, that helps to deaden that whole area in terms of sensation. The patient doesn't experience any pain, thus they don't need as many opioids. So it's very opioid sparing. You'll see this a lot. It helps to speed up the recovery time for your patient and get them discharged sooner. So you'll see that used more and more frequently as time goes on. There's a lot of muscle relaxants we can use too. This is good for patients who have issues where the pain is causing like spasming of the muscle. And then that spasm causes more pain, which causes more spasm. So these are useful for those types of pain there, and these basically work to decrease the ability for those muscles to really kind of contract as much by affecting GABA B. Basically, GABA is a primary inhibitory neurotransmitter. There's two types of receptors, GABA A and GABA B. GABA B is going to be mainly responsible for this muscle relaxant effect and just helps to decrease spasticity. GABA A is going to be more so for seizures, which we'll see next week, I think. So basically, it's going to help to interrupt that spasm sort of cycle there, and it's really good for like rehabilitative purposes. So if you have a patient who's like undergoing PT and they're having a lot of issue with some of the muscle spasm and things like that, this can be really useful for that. Helping out with therapeutic exercise is all really good. Problem is, it does cause sedation and does cause things like dizziness and can cause ataxia. So be aware if you're adding this on top of other things like opioids, you can see a lot of synergism there. Okay, be very careful from that standpoint, but they do develop tolerance over time to this. Main agents you'll find here include things like baclofen, cyclobenzaprine, metaxalone, methocarbamol, and then tizanidine. Again, as I mentioned, that's part of that trifecta that you'll see some patients being prescribed: opioid, muscle relaxant, and a benzo. And that triple combination is just super sedating. So be very careful ever mixing those combo meds together. But once they're used to it, then they may be on this for years. Capsaicin is something I mentioned a little bit, I think, last time when we were talking about rheumatology. But again, this is useful because it helps to deplete substance P and basically prevents, once you have that depletion, they can't sensitize those pain fibers anymore. So again, patients have to take this consistently in order to see any benefit. And unfortunately, most patients will not stay compliant, and for it to allow it to be useful, basically. So that's one of the big negatives to it. Note that it is good for like local areas of pain, not going to be good for like systemic pain issues. Otherwise, you'd be slathering up the whole patient. That's not going to work. Very good for like post-herpetic neuralgia, things like that. Very, very handy. Keep in mind that you want patients to either apply this with gloves on or to make sure that they are using soap and water to clean this off of their skin. Otherwise, this will act just like the capsaicin you find in jalapenos and other spicy peppers. If they touch mucous membranes or their eyes or anything like that, it's going to cause a lot of pain. and heat, not great. So again, the main point here is that the capsaicin is lipophilic, so you have to use soap and water. If you just use water, it's still going to be there on the skin. You can still cause a lot of irritation to the eyes and things. So think about like chopping up a jalapeno or another pepper. You got to wash your hands very, very well. And in fact, I think a lot of when COVID was first new and they're talking about washing your hands, they said, imagine you just cut up a bunch of jalapenos. That's where how you want to wash your hands, like really thoroughly to make sure they don't have anything left over there, or just use gloves. Okay. Um, Odell's was saying if you're combining a muscle relaxant with an opioid, can you just time them out for them not to be taken at the same time, or should they not be used together at all? I'm not saying not to use them together at all. I'm just saying make sure you have a really good reason or really good plan to use them, if and as long as you have experience doing so. Just because you time them at different times of day, they can still have a lot of overlap depending on how long acting they are. So for instance, if you're taking like OxyContin, which is long acting oxycodone throughout the day, that's lasting 12 hours at a time basically, 8 to 12 hours. And so that's going to be interacting at any point when you take a muscle relaxant with that. So again, just be careful. If you need to go lower dose and titrate up more slowly, I would definitely recommend that if you're adding it onto a regimen that may already be sedating to begin with. So good question though. Another drug here, we have tramadol. This one is used as both a partial opioid agonist, so it's kind of like a wimpy opioid, but then it also has this reuptake inhibition of norepinephrine and serotonin. So that was what makes it good for neuropathic pain issues. For a long time, this was not a controlled substance, and so this was sort of like bread and butter for NPs and PAs because this was like the strongest thing you could prescribe for pain. However, it is now made a C4 due to the fact that it is, does have some abuse potential associated with it. Because if people couldn't get access to things like oxycodone, they would just abuse this instead because it was easier for them to get, large quantities of it. So again, similar side effects to the opioids. You're going to see sedation, dizziness, constipation. So be aware of that. And again, it can be reversed with naloxone, although it's not fully reversible, which makes it a challenge if someone is like, not breathing because of this being on board. And you'll see it used with acetaminophen too a lot of times. So Ultraset is a combo pill of those two there. But yeah, weak opioid, but good for neuropathic pain, basically. Now, marijuana is something I want to touch on briefly here. So this is something that's been available for medical use in Florida since 2016. And who knows, maybe we'll change that to recreational use in the future. Who knows how that's going to go. But for medical purposes, and again, as a PA, you cannot prescribe medical marijuana in Florida at this current time of recording. However, you may be dealing with patients who are taking this. You may be working with providers who are prescribing this. Again, they have to go through special training to get certified to do so. And basically, the law states you can use it for any of these conditions here, so like HIV, cancer, things like that. They put a little caveat at the end saying any other debilitating illnesses you think where it might be useful, basically. So they kind of leave the door open to kind of use it for whatever you want in terms of that. So, fortunately for most of you, you probably qualify for PTSD after taking my class and PA school in general. So, you could get your green card, so to speak, right away. Just kidding. Now, cannabis itself is pretty complicated from a pharmacologic standpoint because it has so many different cannabinoids in it, and we don't really know a lot about what it's doing necessarily. And so, we know about some of the main players here. So, for instance, like Delta 9 tetrahydrocannabinol or THC, that's the main psychoactive component. We know that's what causes the euphoric sort of effects, what causes the anti-nausea effects, what's going to be causing some of the the short-term memory issues and things like that. Certainly, I think CBD or cannabidiol has been getting a huge amount of press lately in terms of just like it being used more for like kind of anxiolytic effects, so useful for anxiety. But there's certain seizure disorders that can be treated with CBD primarily. Than cannabinol, but there's a gazillion other compounds that are there that interacting with a lot of targets. We don't really know how they work, right, or what they do. There are two primary cannabinoid receptors in the body, CB1 and CB2. CB1 is the primary one you're going to see being used in the CNS, and so that's the one we'll kind of focus on here. But just know it's going to have a lot of complex interplay with all kinds of neurotransmitters like calcium and norepi and serotonin, all kinds of other effects. So again, it's very complicated. I wish there's a easier way to describe how it works, but again, we don't really know besides the CB1 and CB2 receptors. In terms of risk associated with medical marijuana, again, this can be sedating. You do want to be very careful in terms of making sure patients know not to drive while on this, because it can, lead to accidents and things like that. For some patients with a history of like depression or schizophrenia and psychological behavioral health issues, sometimes this can be exacerbated by the marijuana. So some people get really bad paranoid ideation. Some people can have recurrence of their psychotic symptoms. It's pretty rare, but just know that's a risk. And then from a chronic standpoint, we don't really know, I guess, pun intended, but from a chronic use sort of standpoint, we don't really know the full effects in terms of affecting memory and things like that. So again, we don't have a ton of good research because it's been very difficult to do so, because federally speaking, marijuana is a Schedule 1 drug. So it's been very difficult to do research on it from that standpoint. However, do be careful with pulmonary, use of marijuana, because it can lead to issues, bronchitis and pneumonias. Again, smoking anything is very tough on the lungs, whether it be nicotine or otherwise, because that hot gas really is deleterious to the sensitive tissues of your respiratory tract. All that those epithelial cells take a hit with that really hot gas, which is mitigated somewhat with vaping. But again, long-term effects, the jury's still out on that one. Maybe some association with certain cardiovascular disease, so that would be a thing to consider as well. Ultimately, though, again, the research is difficult to say how effective it is, because again, there's a lot of heterogeneity amongst different strains of the product. Some of them have more THC, some have more CBD. It's difficult to say what marijuana really works best for and what it's really kind of should be used for. So that being said, generally speaking, most of the studies that have been done have found that it does improve symptoms with a lot of these disease states. However, none of them are like a slam dunk. So generally speaking, what I would say, and this is kind of echoed by JAMA in 2015, is saying, if you have one of these conditions that, some evidence exists for, which is that list that was on the law there, I wouldn't say go to marijuana first. I would say try to use some of the other sort of first, second line agents, and see if those work, right? So if someone has nausea associated with chemotherapy, well, then try something like Zofran first before going straight to medical marijuana. If those have not worked, and we don't have any kind of FDA approved cannabinoids like dronabinol, which we talked about in GI, then you can consider using it. Just be careful in those patients that have a history of substance abuse issues, psychotic disorders, etc. So again, probably not first line for anything, but you can give it a try and see how it works for your patient. And again, it's going to be a very sort of like individualized sort of basis there. So no slam dunks, but again, can be quite useful. So that's pretty much it for this section here. So generally speaking, pain is tough. It's tough to deal with. It's tough to say, how to treat every single patient, because they're all going to be a little bit unique. Just be aware of educating your patients in terms of things like don't take extra acetaminophen, don't go driving a car when taking this opioid, things like that, and just be aware of the side effects. Make sure patients are aware, so that way they can know what to look for and how to manage those things. So making sure the patients are on a bowel regimen when they're on opioids for more than a couple of days, things like that are really important. So anyway, so that's it for this section. I'd like to open it up. We have about a couple minutes left here. What questions do you have maybe concerning this or any of the other prior material, since our exam is going to be next week, I believe from 8 to 9. My understanding is you guys are all going to be on campus taking it, so you'll have to do the lockdown browser. So just like last semester, there's an option for you to take a practice lockdown browser test in this week's materials if you want to just make sure that your system's all set up for that. Otherwise, that's pretty much it for me. So I will get your prescription time is graded here pretty shortly. I'll get it done by the end of this week. And then, answer any emails you have regarding questions on the exam. But otherwise, I want to see what you guys have to say right now. So Savannah's asking, quick question about corticosteroid injections into joints. Do patients who rely on that treatment long-term see osteodegeneration in that area of injection? My understanding, as long as they're not doing it too often, because it's more of an issue in terms of causing like tendon atrophy and things like that. So I'm not sure in terms of if you did it for 10, 15, 20 years if we found anything specific, but that's not my knowledge. Not to say that couldn't happen, but I just don't know about it. Yeah, it's more of I think of how often you're using it, especially like throughout the year. I think it's more of the issue than necessarily how long they've been using it in general. As long as it's not too frequent, I think they're okay. What other questions might you have? And again, don't worry about sounding silly because you can put it up anonymously if you want, because I'm sure other people have the same question. And I don't treat anyone like they have a silly question at all because none of them are silly. But I get it can be a little intimidating to ask questions of me, which it shouldn't be because I don't think I'm that intimidating. Otherwise, I'll stay on for a few minutes, but unless anyone else has any questions, you're free to go. You can go ahead and send me an email if you have anything popping up in your mind later on, and otherwise, I'll see you next week. So I'll make an announcement about it, but we'll get started at 9 o'clock next week. So I'll do the live stream at 9. We'll do 9 to 10, and then you can get on with your day. The exam will be 8 to 9. But otherwise, yeah, I'll be with this first 4 sections of Palm, GI, room, and the pain management stuff. So probably 12 to 13 questions on each section just to make it even. Yeah, so should be it. Have a great rest of your day. Otherwise, yeah, see you then. Yeah, thank you. Appreciate you being here. All right, I don't see any questions pop up, so I will see you all later. Have a great day.